Hello friends, I am Dr. Puja Kapoor, Consultant Pediatric Neurologist, Paras Hospital, Director and Co-founder Continua Kids. So here I am today to discuss the topic of autism and its correlation with seizures. Before I start with, I would like to introduce myself, more of it. Previously, I was associated with Artemis Hospital. I was the pediatric consultant neurologist there, and there I used to see a lot of children with neurological deviant children, and I used to refer them for the therapies for whatever is required at different other places. And after they used to go to different places, I could see the trauma that for special therapy, for speech therapy, they have to go to other place. For psychological assessment, they have to go through some other place. And then I thought of conceptualizing something where everything is under one roof. And so the idea of Continua Kids, which stands for Center of Neurotherapy in Uniquely Able Kids, came in. And here in 2016 it was founded. So at Continua we have a whole team which works for special needs children, from a psychologist to a psychiatrist to a pediatric neurologist to a developmental pediatrician to all the therapists, the speech therapy and all. So getting into more of this, the topic which I've chosen is because I used to get a lot of queries for why my child got seizures, how to differentiate, what are the things we have to learn if the child has seizures, how to differentiate between a normal stereotypical behavior and a seizure, and how to treat that. So the topic of today's discussion would be all these. Before I start with, I'll also share a small story of Arnav's mom. This is, I don't remember the parent's name, but I remember my child whom I treat. So Arnav had a seizure, and Kreeti came to me, and so we discussed the pros and the cons and started with him on anti-epileptic. So right now he's fine, and because we became more of friends rather than a doctor and a patient relationship, and so here I am. She invited me for this, and thank you, the special mom, for inviting me. So let's start with the topic of the autism and its relationship with the seizure part of it. So if you'll ask is, what in the normal general population, what is the incidence and the prevalence of seizure is, I would say it is 1 to 2%. That means I have a chance, 2% chance of having a epilepsy or a seizure, basically a seizure in my lifetime. So whereas vis-a-vis, as compared to a child who has got autism, it increases multifold, and the chances increases to 30 to 33% in children who have association with autism. So that is the difference between the two. So in the general population it is 1 to 2%, whereas children with autism, the chances increases multifold to 33%. In fact, sometimes 40%. In some literature it is documented. And it is also associated, if the child has autism, along with that he has a bit of the intellectual disability, the chances increases more. Also, it has been found in children with autism that the peak incidence starts occurring between 13 to 17 years of age. So the peak starts at near about at 13. It's not that the child will never have a seizure before 13, but if you ask at the number, the highest incidence is around 13 to 17 years of age, when the child is growing and the hormonal changes are occurring. And how does it present? Suppose a child who has autism has never had a seizure. How are you going to find out, okay, this was a seizure? So generally the seizure is in children are generalized tonic-clonic. What do you mean by that? So a child could have, he's sitting comfortably or sleeping comfortably, and sometime you will notice that he's having some abnormal movement in the form of tonic posture. Means he can just extend his limbs like this, and there could be some rhythmic movement which is like this. He could have something like this, a regular rhythmic small amplitude movement, and this is what you called as clonic movement. This could last for few seconds and could last for minutes to an hour or so. And this is the most commonest type of seizure, and this is called as generalized. Generalized means whole of the body is involved. It may start with one limb, but it can spread to other, and the whole body could be involved because of that. That is why we say it is generalized. And clonic, I've shown you the movement. This is how it could be. The other type of seizure could be absence seizure. In absence seizure, what happens? The child is doing something, maybe having his food or playing or something, and for few milliseconds or for a second, he just have a staring loop. He just get lost into the just atmosphere. He's nowhere. And once you just put him, just shake him, then he'll come back to that. So it is very difficult in children with autism to find these seizures on a clinical basis, because a lot of these children just go into just vague thing, just stare at something, and those are the type of seizure, and absence could also present like that. So how to differentiate between them? So if you just hold the child and take his name and he comes back in just milliseconds, that means he is arousable, and those could not be seizure. But again, in absence seizure, because those are also very short, and maybe once you are awakening the child, maybe the seizure it's going to stop, and that's why it has stopped. The other thing by which we could be able to differentiate is by an EEG, and EEG stands for electroencephalogram. So like as you do the ECG, that means electrocardiogram, we put it the leads on the heart and we see the electrical activity of the heart. Similarly, we put leads on the brain and we find out the electrical activity of the brain. And this is how you can find out if that is abnormal. We can say, okay, those are seizures, and we can put the child on anti-epileptic. Also, the other clinical features would be the child would be deuterating. You'll say that, oh, we are doing beautiful therapies and there's nothing which has changed in the child, but the child is still regressing. There's some regression. He used to do something and which now is in the regression mode. So some clinical indicators or markers could be there by which we could say, okay, there is decremental response, and because of that, these are seizures only. So there are other clinical features too, and along with that, an investigation like in EEG would help us to sort out the issue and differentiate between the sensory issues and this. The other type of seizure could be atonic. That means a child is sitting comfortably like this, and suddenly the child loses control and just falls down like this. So those are called as atonic seizure. That means I'm losing the tone of my body. I'm just goes off. He could get hit by anything, and those again occurs multiple times in a day, and those again has to be investigated by an EEG or an MRI if you are suspecting something in the brain, and then anti-epileptic has to be started based on the individual basis. So these are some type of seizures which a mother should know, because these are the most commonest one which we see into day-to-day life. Others are also there, but these are the one which are the most commonest and we should know about it. So suppose my child has autism, has got a seizure. So what to do? First of all, please don't panic. You know, even I can get a seizure. Anybody can get a seizure. So the most important thing is that please don't panic, because in panic you are going to do more harm to the child rather than doing good. So once you know, oh, there's something wrong with my child and this could be seizure, first of all you have to make him head turn lateral, lie him on some bed, make sure there is no sharp thing around so that the child does not get hurt, make sure that he does not fall, and there is a comfortable side lateral position has to be managed, so that whatever the salivation occurs, because once you have seizures you become unconscious and you don't know how to swallow your saliva, so there is a lot of pooling of saliva and which could choke your the windpipe and cause respiratory problems. So what you have to do is you have to just shift the lateral positioning so that the saliva drools down and it does not goes into the windpipe of the child. And then what you have to do, you just have to call your doctor or take him. If the seizure settles down then and there in like 1 or 2 seconds or maybe a minute, then it's okay. Else, if this is a seizure beforehand, you know about the seizure and you know about the midazolam spray which we give to every child who has seizure. These are sprays that causes stopping of the seizure if you spray in the nose. And once a child has the first seizure, we tell the mother, inform the mother about these sprays, so that in future if the child has seizure, you just don't panic. Put him on the lateral side, make sure that the where you have put the child is all safe, there are no sharp objects, he's not hit, he does not have some bruise or some bleeding. You look into that, and then in a meanwhile you search for your spray and spray it. That is weight managed. That means higher the weight of the child, the number of sprays increases, and as soon as you will spray the child with the midazolam spray, the seizures would stop. If you don't know anything about midazolam, it's better to take the rush to the hospital to get the primary first aid done for the child, because there they will put the IV and put the midazolam, again the spray thing, only into the intravenous route, so that the seizures stop. So generally, small seizures do not cause a lot of brain injury, but if it's like a constant status thing, that the seizures are continuing for more than 15 minutes, that can cause some injury in the brain. So it's always better that if the child has, you just don't have to wait for the child to cease for so long, and you have to go to the doctor for the abortion of the seizure if you don't have the midazolam spray at your place. Now, if that has been sorted, the other thing which you have to look into thing is the start of anti-epileptic. That means if a child has the first seizure and the EEG, you do an EEG that is more or less normal, what to do with that? So generally the rule says we don't start with the anti-epileptic after the first seizure. If the EEG is normal and the child has very less chances of having seizure, because we wait for the other seizure to come, because the chances increases after the second seizure. So once you have the second seizure, then obviously we have to start with an anti-epileptic. Or if the EEG is real bad, or if the chances, looking at other all conditions, if the chances are very high of having a seizure, then we start even with the first seizure. But generally we wait and ask for the second seizure to happen, and then we give it to the, then we start with the anti-epileptic medicines. So a lot of parents don't give anti-epileptic. I have to say this at this forum, because I have a lot of parents who think there are so many side effects of the anti-epileptic that they avoid giving it. It's my request to the parents that we as doctors would like to start. We always start the anti-epileptic at a very, very low dose. We don't start at a high dose, which does not cause a lot of harm to the child. In fact, the seizure could cause a lot of harm to the child if they are more recurrent, or there are silent seizures. There are some seizures which are silent seizures too. I wanted to discuss in detail about that. I'll discuss in a while. So sometimes it happens because of these silent seizures, my child is not progressing as he or she should progress with the therapies. So make sure if the child, if your consultant doctor have asked you to start with the anti-epileptic, please do so. I agree to that. There are a lot of seizure medication which cause side effects, but at a lower dose, at a dose which is we start with for an autistic child, these are generally very low. The good thing about the seizures in autistic children is that they happen in 33% of the children with epilepsy, with autism, but they are very infrequent. That means that if you start with a small anti-epileptic, we will be able to tide through a long period. Like with other epilepsies which are very dramatic and we require 2 or 3 or 4 anti-epileptics, and so a large number of side effects. The good thing about the seizure in autism is that even though they are very, very high rate, 33% in autism, but they are treatable by very small anti-epileptic, and only one anti-epileptic can do wonders for a child. So you have to make sure that at a smaller dose, the child could be very well titrated and the seizures could be stopped, and that is the good thing. So it's always better to start with an anti-epileptic and have the safe child rather than recurrent seizures when you're rushing due to the OPDs, rushing to the hospital emergencies. So the next thing is like, I want to discuss about silent seizure. So as we know that we don't know a lot about the causative agent of why my child has autism, and specifically the idiopathic autism. So there are two types of autism. First is you have a cause behind. That means in a child who has got a very stormy neonatal course, he was admitted in an NICU, had certain hypoglycemia, that means the sugar went down when he was very small and was admitted in the ICU, or had some trauma or to the brain, had some bleed or some other brain injury. In those children, they have very typical different type of seizures which are called as infantile spasm. That means they just jerk like this and they will be all normal, and these seizures cause secondary autism later in the life. So they have these seizures at the age of 4 months, 5 months, and the parents think this is called as chokna in our normal vernacular language thing, that ye to halka sa aise chonk raha hai, but these are very mild seizure, but the long side effects of these are they land up into secondary autism. Again, there are other clinical entities which can cause secondary autism, like tuberous sclerosis, which you can discuss with your doctor. And the other ones are idiopathic seizure, which a majority of us have. That means there is no cause, there is no pathology, but it has been found that few children, they have specifically all those autistic children who have got regression at a later stage. That means by 9 months, they started with some babbling, they started with a beautiful eye connect, and then after 9 or between 9 to 18 months, they have a regression of the milestones, specifically social milestone. They will walk, they appear out to be normal, but they have a regression of the milestones of the social milestone specifically, and speech milestone. Specifically in these children, they have been found few of them can have EEG abnormalities, and because of that they land up into autism, which again is secondary, but we have to look into the cause, that this is not caused by something electrical activity, bad electrical activity in the brain, and because of that it has been caused. So make sure all those children who were normal by 9 months, 10 months or 18 months and then they started showing regression should have an EEG to be done, and make sure that these regression is not because of some electrical activity in the brain, not because of the silent seizures. And once you have got out, it is clear, then it turns out to be idiopathic autism. That means I don't find any cause and it is idiopathic. So in idiopathic epilepsies, that is one thing which we have to make sure that it is the other causes has been ruled out by your doctor, and you turn it into an idiopathic epilepsy along with autism. So what next? So the most commonest, I'm just going to discuss the commonest side effect of the most common medicine which we generally use in our children with autism, with epilepsy, and that is called as sodium valproate. Or it comes, I'm not going to give the brand names. Sodium valproate, it has valparin, sodium valparin as a salt, and the only side effect, the major one, is because it causes a lot of appetite, increase in the appetite and weight gain. So, but at a very small dose, which we start generally, and the seizures get controlled, we generally don't get these side effects. But for your knowledge, you should know that appetite is to be monitored, so that you don't give him very high energy food in the form of high sugars, carbohydrates or high fats. Protein is better, and you give more green vegetables, so that the diet, you just cannot manipulate the appetite. You have to give food to the child whenever he or she asks for, but obviously the quality of the food can be managed by giving more fibers and more green vegetables and more salads before giving the full meal to the child, so that the weight is monitored. The other side effect is hepatotoxicity. That means a liver thing, but generally in children these does not come as frequent as in adults, so that is not and we also monitor it accordingly. we just check upon the liver functions in children who have these who are on sodium valproate. So this is the side effect which you have to look in for. Apart from that, no, you should, I mean, the drug is more or less safe for the children with epilepsy, with autism. And we also use this medicine with other in epilepsies very frequently. So we have not seen a lot of side effects from these medication. So I have got a lot of questions which are there. I think I will answer those and then I'll come back to the topic if the time permits. But I guess that the midazolam sprays are not an over-the-counter sprays. We need a doctor's prescription. Yes, definitely you need a doctor's prescription. Any medicine which is related to brain are not over-the-counter medication. You have to have a prescription by a doctor and then you can have that. But you should have it. Generally a doctor who, once you have a seizure, prescribes you so that the subsequent seizures are managed well. There is no panic condition. If the hospital is very far off from your place, you spray to the child, relax, and then you can call your respective doctor to what to do next if the seizure stops. If the seizure don't stop even after giving midazolam, obviously then you have to rush to the hospital. But these are very good medication. You buy in time and the child becomes much better with that. So I have noticed, the other question is by Miss Manisha. I have noticed minor body twitching while falling asleep or even during early sleep. So you have to check upon, because sometimes the child, these could be early markers for the seizure. I don't know the age of the child. I should know the age of the child, because there are certain type of seizures which are called as, again I'll discuss, infantile spasm. Infantile means in the age group till 1 year of age. So child who has twitches specifically during falling asleep or during early sleep, that means in the drowsy state, could be an infantile spasm and could have regression associated with that. So kindly check with your doctor for that. These cannot be ignored. These are just simple benign movement or could be infantile spasm that could be elaborated only after a good history, and also by knowing and having a video thing that what are these. But by looking at just a line which you have mentioned, I think you should refer to your pediatric neurologist and ask for what is this happening. Make a video of these, because video of the seizure really helps the doctor a lot, because sometimes your description won't be able to make much of the, you cannot describe the event, but a video of the event is what a doctor is looking in for, and that will help us to decide whether these are seizures or these are just benign movement. By benign I mean nothing has to be done, and a lot of children do such movement, so that has to be sorted out. And according to, there's another question by Miss Sudeshna Bishwas. What about if the child has got regression after MMR vaccine? So there was a lot of hue and cry of MMR vaccine causing regression, but that has been long back disapproved. So the theory was given by Dr. Wakefield, who was a gastroenterologist at UK, and he found a correlation that as we give the child MMR vaccine, there was a regression in the social milestones, and that was associated with a lot of autism. But a lot of research, I mean, this has been very well proved and got off that MMR vaccine now has no relationship with the, as a causative thing for the, for my autism. So make sure that you vaccinate the child well, because that theory which was published in Lancet is our Bible in medical science, but that was retracted from that, and that doctor has been banned for giving a false finding, because it was very well investigated, and now this theory has been falsified. And even in a lot of European countries, because there is a very strong vaccine lobby which say that this is there, and because of that a lot of children in Europe have stopped giving MMR vaccines. And there are a lot of measles related, MMR stands for measles, mumps and rubella. A lot of children, small children, had measles encephalitis, that means their brain got infected with measles, and there was a lot of distraught which was brought into our children because of the stoppage of this vaccine. So it's my kind request, don't stop this vaccine for your children. This is a preventable disease, and till now we haven't got a solid substance, a solid causation thing between MMR vaccine and autism. There's another question by Miss Nay. My son Kaushal, autism, non-verbal, going to be 21 years in September, having seizures since the age of 3 months, still having fits once in a month, having medication from PGI Chandigarh, almost 20.6 years. So you have to find out what is the cause. Like if you are giving, there has to be a good compliance issue. That means you should give your medicines on time. There should not be any delay. Plus adjust the medicine according to the weight, because my child has become an adult now. I'm 21 years of age. So you have to titrate the medicine also. That means the dose has to increase and get to the adult dose, because the seizure started by the age of 3 months. So I believe that you must have titrated, the doctor must have titrated the medicine. And also what we see is that, suppose if the child has a seizure only once in a month and the side effect of starting add-on anti-epileptic, that means addition of one more medicine to the pre-existing medicine is more, then we don't start and explain the mother, because it's once a month. So we always titrate what is causing more harm to the child. It is the medicine which is causing more harm to the child, the side effect of the medicine, or the seizure. So I need to know the whole history to find out why, because PGI Chandigarh is a very good institute and they must have reasons. You should talk to your doctor why. Can we add some other medication to stop the seizure, or the seizures may be so small that they don't want to add a lot of medication because of the side effect, or the dose which has to be adjusted. There are so many things with these things that we have to find out. So I would only be able to answer you after I get all the answers to all these questions which I have asked. The other thing is by Miss Jyoti. 3 days back in evening, I was doing some activity with my son who is 7 years of age. Suddenly he stopped responding, was looking in one direction. We kept on calling, shook him. He was looking drained, not eating anything, not even drinking water. Please tell. Definitely this could be a seizure, as I've explained you. This could be a absence seizure, atypical absence. Kindly get to your doctor, because a child who is perfectly fine and is doing activity and suddenly stops for a while and do nothing. So those could be the very closest differential of seizure. Closest differential means there could be some other things like stereotypies, that they just are not interested and they're looking somewhere and they don't follow your command. But looking at what you have described, I feel that this could be a seizure. A differential could be a seizure. So definitely you should consult a pediatric neurologist and do an EEG and find out whether these are seizure or not. Try to make a video if something happens next time, mummy, because that is what is going to, your doctor is going to ask next from you. Okay, beside doing an EEG. Manisha Mishra has said age is 25. Okay, so I've noticed minor. Mummy, what you have to do is, like, you have to again make a video, because at 25 years an infantile spasms cannot occur. But what it is, I have to know about it. Whether these are seizure, whether these are not, that could be dependent on a video. Also, if required, if the video still does not get more of the information, I need an EEG for that. Okay. The next question is, my son is 20 plus and seizures have started at this age. He is on medication. Will the seizures stop in future? So that depends on, because this is a very late start. So once it's a late start, the chances are lesser that you can stop the medication. And but the rule says, whatever may be the condition, if after 2 to 3 years, if the EEG is normal and the child does not show no seizures for next 2 to 3 years, we can taper and stop. and see what happens, because everyone has got a different trajectory, everyone has got a different cause for the seizure. Because I'll tell you, like I've told you, that in children with autism, along with a bit of low intelligence, have more chances as compared to a child who is just have autism. So depending on what the condition of the child is, it all depends on for how long it is. Like my EEG, my other clinical features will describe me for how long I have to give the medication. But definitely we give it for 2 to 3 years. If there are no seizures in these 2 to 3 years and the EEG at the final stage shows me no epileptiform discharges, the child is good, then we taper and still see what the response would be. If the child throws in seizures again, then again we'll start it for another 3-4 years, and then so this is how we proceed. Presently, so Sneh has said presently he's on Valproate, Levipil, Frisium, Topamac and Zeptol. Are those seizures or not? Please. So once a child who is on 1, 2, 3, 4, 5 anti-epileptics and still having seizure, I have to see whether those whatever you are describing are real seizures or we are treating something different. I need definitely a video to find out what are these, because to give a child 5 anti-epileptics, I'm not going to add anything more. In fact, I'll just taper on and see what the condition is. And if in spite of giving if those are seizures and we are giving 5 anti-epileptic, definitely I'm not going to add any other anti-epileptic. If it's like 1 seizure per month, I'll live with that rather than adding more. Also, I'll just check upon that the dosage are all right, and because these are so many of medicines, I have to check on those aspects too. Okay, sorry, not once in a month, it is once in a week. Okay, so once in a week is quite a good frequency. I again have to check on what are we giving, because to have a child on 5 anti-epileptic is a big thing. We can try something which is called as ketogenic diet in these children, because sometimes if my the anti-epileptic doesn't work, there is a thing which has come in and it's got good results, which is called as ketogenic diet or modified Atkins diet. These are special types of diets in which we decrease the carbohydrate content of the food which we give to the child and we add more of the fat. And it has been found that once a child who we titrate the carbohydrate and the fat and the protein content in the diet, those could lessen the seizure and with less of side effects as compared to other anti-epileptics. So I need to discuss this case definitely and find out if there are other reasons or there are other things could also be tried apart from just giving medications to the child. Because once a week, now you have said, is like 4 times or 5 times a month is big number. So Jyoti has written, okay, no ma'am, this happened first time and it went for, this is the one, Jyoti, the seizure type is, which she has described that once she had 3 days back, she had like the child who's 7 years of age just stopped responding in one direction. So definitely I'm looking in for as the differential as the first seizure as the first differential, but if this happens next, please make a video asking for, because this is looking like a seizure. Why again this is looking like a seizure? Because what happens in a seizure is like there's a lot of electrical activity which goes in the seizure, and as soon as the seizure stops, the brain just goes in silence. And these children, if the seizure stops, they just go into very deep sleep. So as you have written down, then he slept for 2 hours. That means could be this activity was from brain only. I would definitely work on this child in a form of EEG and would look in for seizures, because if the seizure is there, it's going to come again next. So one thing is which differentiates stereotypies from the seizure is that because the child has one side head rotation, so that means this does not occur in stereotypies. Also that the child slept for 2 hours. So a normal child who was just doing some activity and suddenly after this episode of 2 minutes, 3 to 4 minutes slept, that means there was something wrong in my brain, some wrong electrical activity in the brain which caused my brain to sleep. So I would definitely, Jyoti, I'm going to, you should work on that this could be a seizure and rule out. And check always that this does not happen in the near future. If this happens, go for an EEG, refer to a pediatric neurologist to make sure that these are not seizure and something else. Okay. So I think I have answered the questions. So this is all I have. So I think I've made some sense out of this. So again, there's one more question. What are the chances of having seizure in autistic children, and what is the age we should be watchful for? Okay, I think you missed the initial part of it, Prachi. So in the start, I already told that for a normal person, normal human being like all of us, there are chances in the normal population of having a seizure 1 to 2%. Whereas in a child who has autism, the chances increases to 30 to 40%. That means there's multifold increase in the chances of autistic children to have a seizure. That means out of 100, there are 40% will get a seizure. And at what age specifically? There is like 13 to 17 years age is the age when they come in. The incidence is very high at this age. Are there any pre-epileptic symptoms? So pre-epileptic, no, the child will be maybe some agitation, something, it could be. I'm not saying that in every child you could have. So there are certain seizures which are precipitated, they have auras before that. What do you mean by aura? Aura is like you have some different sensation before a main seizure come in. They become more irritable, maybe they come and hug you because they are not feeling good. There's something happening in the brain which is not good to them, and maybe they will the irritation increases, and they are not doing so great as they used to do for a while, and then the main seizure comes in. So the aura has to be looked into, and that is that could be a pre-epileptic symptom. Question from Shalini: is CBD oil recommended in teens where there is no optimum seizure control? So for the CBD oil, there's a lot of research has been done, but not I mean these are plus minus. These are not very solid evidence that CBD definitely causes a lot of seizure control. There is plus and minus, and also there are side effects. So I would not recommend that that you should start CBD in the first go. Try the other anti-epileptics which are much less harmful, which are much better as compared, and they have got a good literature which is supporting them as evidence for the stoppage of seizure rather than starting CBD oil. Are there doctors that will help in Delhi NCR introducing this? Definitely all the pediatric neurologists knows about it, and that is, we know it, but we haven't seen in our practice that it really helps. Though we certainly we tried other things rather than starting with CBD and a first go. The other question is there issue if a child had medicine for seizure in morning which he is supposed to have in night? So definitely seizure medication, if started, has to given on time. You cannot play with the seizure medication. If the time you have set is 8 a.m. in the morning and 8 a.m. in the evening, it has to be like that. You can shift it like for 15-20 minutes, but you cannot, like days you give at 8, the other days you give at 10, the other days you give at 12. No. So once you give the medication, it goes there, get absorbed from the intestine, then it goes to the brain, in the blood and the brain, and a level is maintained once you give the medication. So if you just don't give it at time, so suppose if you give it at 8 a.m. and the next dose is at 8 p.m. and you haven't given it, so the blood level of the medication will really go down and the child could throw a seizure. So make sure that you give it on time, please. This is very important. You cannot skip the medication once it is started. This is very important. A very important question was asked. So the other question is from Vijay. My son, 3.5 years, had abnormalities in EEG, and we used the Valproate for 5 months and not seen any changes in it, and we have not seen any physical presence of seizures. So again, this is a very good question. that we don't treat the EEG. The take home message would be, I am not saying that if you're the EEG is bad. In a lot of children, the EEG could be some discharges anywhere around, and but if you don't see a change in your, if there's no seizures which are there, if there is no regression of the milestones, if the child is not improving, then I talked about silent seizure. But the EEG is just showing only marginal changes and not specific markers and not specified changes in the EEG. I would not recommend to start anti-epileptic. Mind it, in 10 to 15% of the normal human being can also have an abnormal EEG. So this is not an indication to start anti-epileptic. So you have to make sure that there is something associated clinically which tells you, okay, then do an EEG, and if the EEG also is collaborating with my clinical findings, that is the indication to start an anti-epileptic. And because it is very difficult in a child who has got sensory phenomena in an autistic child apart from silent seizure, so you have to make sure, that is what I'm telling time and again, make videos of the child, because that there are so many clinical features by which we will be able to differentiate, okay, this could be just a sensory phenomena, this is not an seizure, this is not absent seizure, these are not atypical absent seizure, or these are not silent seizure. So talk to your doctor about it. Okay, what are the, and why you did an EEG, what were the pre-findings on the EEG, how much bad the EEG is to start an anti-epileptic. So make sure these are all the things. The final take home message is, don't just do an EEG in every child of autism and ask for if the EEG shows 1 or 2 spikes somewhere here and there. So those are not an indication to start an anti-epileptic. Make sure this is the take home message. Okay. So, okay, Vijay again, at the time of birth, he was admitted at ICU due to less sugar. Question from, okay. So again, what does an MRI shows? Why was there association of low sugar in the brain along with my MRI? Also, the type of seizure generally in these children, as I've told you, in the early infantile period is like infantile spasm like this. Did your child had those seizures? And now what their seizures apart from just a bad EEG? So everything has to be looked into. Like you gave me a history that it was like associated with a hypoglycemia, that is low sugar in the neonatal period. But that low sugar, was it associated with some MRI changes? Was it associated with some physical changes? Was it associated with some infantile spasms in the initial age of the 1 year of the child? If those were, then those could be seizures later on, because these children have very difficult epilepsies. Then I would support your finding of an EEG or of seizures, but not before that. So definitely you need to discuss with your pediatric neurologist about all these things. Question from Vandana. I have a patient taking medicine for ADHD, feeling suicidal thoughts with no reasons. Yes, a bit of the ADHD medications are associated with suicidal thoughts. You can definitely change. You can discuss this with your pediatric neurologist, and you can definitely change the medication. I don't know which group you are taking, because definitely there's one group which is associated with suicidal ideation. For those, definitely you can consult your neurologist and can change those. Query from Arika. Jerk in hand and legs while sleeping only. Son is 4.8 years. So again, I'll make sure you that sometimes we also jerk when we sleep. Those are called as sleep myoclonus. Like some jerk, if you observe a child who's sitting, a normal child who's sleeping in deep sleep and suddenly shows a jerk. So those are normal jerks. But a child who has jerks in the start of the sleep, that means in the drowsy state, plus has regression, plus have some history which is there in the neonatal period, definitely I'm going to work on those. Whereas simple child who does not have any history, who's thriving well, there is nothing which we have seen, and in deep sleep he just jerks something, some jerk like this, that obviously I don't think so. Those goes in favor of seizure, but definitely make a video, discuss with your pediatric neurologist. It has to be discussed. Again, take a video. So those again have a differential of a seizure or non-seizure. Those are called as sleep myoclonus, which we also have sometimes. Anybody can have. Okay, Vijay says that MRI shows patches with HIE. Okay, so then you have to go to the EEG. If the EEG is really bad, then definitely an anti-epileptic has to be given and check upon. Maybe those are silent seizures which you are not able to observe. Maybe those seizures are just associated with regression. That means the child is not doing well in spite of the therapies. So that's why your doctor must have given you anti-epileptic. Wait for that and find out the reason. What if EEG MRI normal for 16 years but is having seizures since March 2020? Medication started. What can we do for clear diagnosis? No, sometimes the seizures just come like that in anybody. So those are called as idiopathic seizure without any cause. If your EEG is normal and an MRI is normal, but definitely the child had seizure. The one thing which we have to make sure that the child should have a seizure. You have to well document that seizure and then we start with an anti-epileptic. Also, we don't start with an anti-epileptic with only the first seizure. Epilepsy is once you have the second episode and then we wait. Because in a normal child who's got a normal EEG, a normal MRI, the chances of having a next seizure is very less. Only 30% chance and 70% chance the child may not have a next seizure. So generally we don't start with an anti-epileptic with the first seizure and there are no precipitating factors. The MRI, as you said, is normal in a normal child. So you have to check upon that it has to be a second seizure to start with an anti-epileptic. What about melatonin? Should it be given? Definitely, if you have melatonin is a beautiful drug, although it has not been FDA approved, but still it has got no side effect at all, documented less of those. It is just a hormone. As soon as we close our eyes, the pineal gland of ours starts secreting a hormone which is called as melatonin, and which could be very well given for the initiation of the sleep and for the it helps in the initiation of sleep in these children who have got sleep issues. You can definitely give it along with 3 AEDs. Yes, definitely it can be given along with 3 AEDs also. ADHD medication in child with ASD and ADHD. There's a lot of medications which can be given for ADHD. I think I'll not discuss this because this goes beyond my topic. But yes, there are a lot of medication which could be given in a child with ASD and ADHD. And those are divided into 2 groups, stimulants and non-stimulants, which we can discuss maybe in the next session. Jerks in head while he's eating, brushing and watching TV. So again, it could be seizure and it could be non-seizures too, because it is not that seizure always come by some activity, like you said, only during eating, only during brushing and watching TV. So if it has to be like in any way, seizures can come in any circumstances. So less likely that it could be seizure, but definitely you have to check with the video, consult with your pediatric neurologist and ask for, because the video is the best thing. But looking at the circumstances where it comes seizures only in 3 circumstances, the chances are that it is less likely to be a seizure and more likely to some stereotypic behavior or something else. So the same 16-year-old child took morning and evening dose together. Today only we will take care of in future. Definitely, please make sure that you don't give the drugs together, because then once you give in, the titer goes very high in the brain and then it slows down. So the take-home message is that anti-epileptic medicine has to be given in a very timely basis. You cannot just dump in at one time. There is a science behind of giving the medicine at equal interval of few hours, maybe 12 hours, maybe 8 hours, whatever is prescribed to you. Okay. I think I've done with all the questions. There are no more questions. If you have, you can type in all those and I'll just get back to you, and the special mom page also will get back to you on those for the answers. I think it was a lovely talking to you all, and I hope I added something to the knowledge which you already have and could make some difference in the life of our children. Thank you very much. Take care.